we operate. I'm going to go ahead and introduce our first guest speaker, Dr. Glenn Wortmann. He is currently the chair of infectious diseases at MedStar Washington Hospital Center and medical director of infection prevention at MedStar Health. He completed his undergraduate studies at Princeton University on a 4-year ROTC scholarship and pursued his medical education and internship at Medical College of Virginia in Richmond. He fulfilled his residency along with an ID fellowship at the Walter Reed Army Medical Center. He left the Army in 2012 after a 23-year career with tours in Germany, I apologize, I can't quite pronounce that. Thank you. Walter Reed, Afghanistan, and Iraq. Before I have him move forward, if you do have any questions as we're going along, please make sure to put them into the chat box throughout the presentation. That'll make sure that we can capture them later during our Q&A portion. Okay, Dr. Wortmann, you can take it away.
Great, thank you so much for having me tonight and calling in this evening. So I'm gonna go over some treatment and prevention issues with COVID. Next slide. So a little bit about our current state. Where are we right now with COVID? It goes up and down. So these are the national numbers, and we're in a good place right now. With the Omicron surge, you can see that great big red line there. We've come down, but it has not gone to zero. So we are still seeing a low level number of cases. Next slide. This is DC specific data, and it mirrors what we see nationally. There was that big surge of Omicron and now low level, but you'll notice this is from April 15th. We're starting to see a little bit of an uptick, and that's what we're seeing at our hospital and around the clinics. We're starting to see a little bit of an uptick with COVID recently. Next slide. Now, some good news. These are deaths. So this is deaths from COVID in the United States. And again, with that Omicron surge, there was a big increase in deaths. But that line continues to go down. So what we're hoping to see is through vaccinations and better treatments, although people may get COVID, people dying from COVID should really drop to low levels. Next slide. So as far as the strains that we're seeing, this graph shows you what's been going on since January 8th, and then moving to the right. It's all been Omicron. And a specific variant Omicron called BA2 is now the most prevalent strain. So as of April 9th, the 22nd, the pink bar to the far right, it's pretty much all BA2 variants in our area at this time. Next slide. So a little bit about COVID in general, and it's a very interesting virus because many people are completely asymptomatic. So they'll just test positive, but have absolutely no symptoms. Then if you move to the right, we have people that develop a mild illness. They'll have a typical cold, sore throat, runny nose, a little bit of a cough. But then we get into the moderate illness, and these are the patients that we see here in the hospital. They'll have more severe disease. They'll have x-rays showing evidence of pneumonia. And then with severe illness, they'll need extra oxygen to help them breathe. And then with critical illness, we see people die of COVID. Why is it that some people have no symptoms and some people die? We still don't completely understand it, but it has a lot to do with you as the patient. If you're 22 years old and otherwise healthy, you're going to do fine with this infection. But if you're 70 years old, you've not been vaccinated, and you've had a kidney transplant, your risk of having a critical illness is much greater. So there are some variables you can control, such as vaccinating and getting early treatment, but you yourself as a patient really control where you're going to fall on this spectrum of illness. Next slide. So we'll go over treatment, and first I'm going to talk about treatment in the outpatient setting. And this is a slide I stole from Dr. Werbel, who presented it at a national meeting, and I like the slide so much I just copied it and I'm using it. But it goes over when we decide to treat people. So if you're in the green zone, so you're under 30, you have no medical illnesses, you're fully vaccinated and you're not in any medicines that impair your immune system, you really don't need any treatment. You're going to do fine. The risk of you having a bad effect from COVID-19 is so small, you really don't need any treatment. But as we move to the right, as you get older, you start getting into that red zone. If you have some comorbidities, so you have diabetes, for example, you're pregnant, you have COPD or asthma, that's going to push you to the right. If you've not been fully vaccinated, you haven't had your booster, or you're not vaccinated, that's going to push you to the right. Or if you're on medications that suppress your immune system, such as you have a cancer and you're on chemotherapy, or if you've received a renal transplant, all those things are going to push you to the right. So when you test positive, this is a discussion you need to make with your doctor to say, do I need treatment? And if you fall towards the red side, you're going to need treatment. If you're on the green side, maybe not, but on the red side, you definitely need treatment. So when you go and get tested, you kind of think about where you think you fall on this and then discuss it with your doctor. Next slide. So right now, we're very fortunate. There are 2 pills which are available. They're useful if you have symptoms for less than 5 days. So if you have symptoms of COVID, you need to get tested as soon as possible because the clock starts ticking. You only have 5 days to get that treatment in. The number 1 treatment is something called Paxlovid. I'm going to use the trade name because the generic name is too hard to pronounce, the nirmatrelvir ritonavir. It's 3 pills twice a day for 5 days. It's not for everybody. It interacts with a lot of other medicines, and your provider will actually look to see if this drug is safe for you to take. They may tell you, stop taking your statin for a few days while you're on this medicine, but there's some drugs you can't stop. And so this drug may not be for everybody. But if you can take it, this is the number 1 drug, helps prevent you from dying and being hospitalized with COVID. The other option is something called molnupiravir. Also needs to be started within 5 days. In the studies, it doesn't work as well as Paxlovid, but it's better than nothing. So if you can't take Paxlovid because of some drug interactions, molnupiravir would be another option for you as far as oral therapies. So again, if you're falling in that red zone, 2 options for you for treatment. Next slide. This is a side-by-side comparison looking at molnupiravir versus Paxlovid. And you can see why I prefer Paxlovid. It had an 89% efficacy versus molnupiravir was 30%. So just not as good. But if you get down to the drug interactions row, that's where Paxlovid has problems. Next slide. There are some intravenous therapies, some IV therapies that we offer to people. So let's say you cannot take Paxlovid and you're a very high-risk patient, like a renal transplant patient. Molnupiravir, the other option, probably isn't your best option because it doesn't work that well. Here, you want to find a doctor that can get you to something called bebtelovimab, which is an intravenous monoclonal antibody and works very well. We offer it here within the MedStar system, and we can route patients. We've treated thousands of patients with these monoclonal antibodies. It has to be given within 7 days of therapy. There is another option on the textbook called remdesivir, but it requires 3 days of IV infusion. So you have to get a treatment every day for 3 days. We are not offering this within the MedStar system because we just don't have the capability to give an intravenous infusion every day for 3 days. So if you're getting treated within MedStar, we offer the 2 pills, or we can give the monoclonal antibody, the bebtelovimab. Next slide. For inpatient therapies, I'm not going to spend a lot of time on this slide because it's fairly complicated and it's in the inpatient setting. So really your doctors in the hospital are going to make the call about what to do. But basically, if you're in the hospital and you need oxygen, we're going to give you the remdesivir. We're going to give you steroids. If you get worse, there are some other drugs we can use, such as something called tocilizumab, that helps tamp down your immune system. Because if you're getting very sick, it's because your immune system is overreacting to the virus. So it gets very complicated, but this is what I get paid to do. This is what the ICU docs get paid to do. And so we pull out this chart and we look at you and figure out what's the best medicine for you. Next slide. So the best thing to do is prevent it. So for prevention, there are vaccines available. Again, it's become kind of complicated, but your doctor, there are apps on the phone to help figure out what's the best vaccine schedule for you. But in general, it's for pediatrics, age 5 to 11, it's 2 doses. I deal with adults, so it's 2 doses. That's the primary series. Then there's a booster dose, and really everybody should be getting at least the 1 booster. And then there's a second booster after that. If you're over the age of 50, or if you have certain immune compromising conditions, you should consider getting that second booster. But this, again, you should be discussing this with your doctor. They'll say, you know, they really should be telling everybody to get the 2 doses plus 1 booster. And then the second booster is a case-by-case situation. Next slide. If you're one of these highly immunocompromised patients, this schedule is collapsed down. We get you the 3rd dose sooner because we try and get you the peak vaccination as quickly as possible. I'm not going to go through this in detail. I just put it out here because if you're falling into that renal transplant chemotherapy patient, your doctor should be aware of this and get you this accelerated vaccine series. Next slide. And, you know, do vaccines work? You know, the data is out there. We see this every day in the hospital. We don't admit patients who are vaccinated. You know, it just doesn't happen. The only patients we're admitting who are vaccinated are highly immunocompromised patients that don't respond to the vaccine. And this slide shows the difference between the unvaccinated and the vaccinated, and it's a pretty stark difference. Next slide. And then my last slide is something called Evosheld, which many people don't know about. So Evosheld is a long-lasting monoclonal antibody to prevent people from getting COVID. And so it lasts for about 6 months. It's given by an injection. You get it in the buttocks. And it's designed for people that don't respond to the vaccine. So if you're on chemotherapy, if you're on these big guns, immune suppressants, I can vaccinate you, but you're not going to respond to the vaccine. And so I will vaccinate you just in case you'll get some response. But then we give you this long-acting antibody, and it lasts for 6 months to help prevent you from getting COVID. So if you fall into one of these patient groups, you need to talk to your doc. We run a clinic here every Friday afternoon. Georgetown runs a clinic, and there's another clinic up at Union Memorial, it's at Franklin Square, up in Baltimore. So within the MedStar system, we offer this to patients. And I think, Dawn, that's my last slide. Great, thank you.
Thank you.